Hi, Don here. Welcome to Podiatry Practice Mastery. I'm going to go over today. This was a Thursday patient day. 21 appointments, 20 minutes opening. This was my busier office. If you've heard, some other days I've been in my Westboro office, which is new. It's been there for a couple of years, and so we're still building it up. So wintertime's a little bit slow. We had a snowstorm here, so there were some cancellations in my day. But one thing I did that was, I guess, fun, and it was the hard work that is not fun to do. I remember recently I was at an AAPPM conference, and one of my faults is I feel like I like to learn things, but then to actually implement them is hard. I don't know if you feel that way. So one of the things I read about, I'm like, this is a great idea. I wrote it out loud. I put it in my little Notion book, which is where I kind of keep my ideas. But I never just did the hard work to do this, which was one of the, so it's the idea of using our own patient list and marketing and following up with them. So what I learned to do with my EMR, and I think most EMRs can do this, I run a report from 1 year ago to 4 years ago, so a 3-year time frame. And those patients that didn't die, those patients that didn't have a follow-up, and those patients that were seen for a certain diagnosis. So the idea is each month you pick a different diagnosis. So January was diabetes, February was ulcers, and let's say March would be AFOs, then the other one would be heel pain. Calling these patients back and just seeing, hey, it's time for your yearly follow-up, just checking up with you. So I did this. So my staff, I printed out, there was 232 people with diabetes and 138 that had ulcers. And these were patients that the practice had seen. Actually, I think they were patients that I had seen in this last time, and then calling back to make a follow-up. So my staff was calling through these. Now, unfortunately, it was kind of morbid because most of the 80-year-olds she Googled and she found that a lot of them had died, which kind of goes to the point of diabetes and ulcers, how people die. But in one day, she was able to call. This was one of the slower days, and because of snow, she was able to make 4 appointments. So I bring this up because, like, for us, a lot of times, like, that's money. Like, she didn't understand, like, the great benefit of that. But for me, there's no one else that's a money producer in the office except us doctors and, like, patients kind of randomly calling. Like, this was a callback thing that worked. And so what my plan is, now you can keep me accountable to this, is like each month print out this list. I printed the list. She goes through it. She highlights who left a message to, who made the appointment, and then who died. So that was one kind of a big win for the day. Other things that I was working on, I don't know. I think I've told you about my dad. My dad's dealing a little bit with dementia, so he goes to this Shrewsbury, where I live, a Shrewsbury kind of men's club, and I got a call from them to do a talk. So I'm going to do a talk, and I was preparing this talk. So I'm going to call this like foot problems for old fogies or something like that. It's going to be a funny name, and I'm going to go through and talk about different things. So I took a half day to be there with my dad and also kind of do that talk. So I was setting up some kind of public speaking things. And then finally, I recorded during my lunchtime. It's something I've been wanting to record for a while. It was a masterclass on cash confidence. Many doctors, they as they're sending me information, they're concerned. They're not really sure how to do more cash things in their office and how to offer it, how to like integrate it and things like that. So I put that together. That's going to be on my it's going to be like on the header of the website, Podiatry Practice Mastery. I'm also streaming it live on YouTube coming up. So you probably get an email about that, kind of offering that so people can watch that live. And then afterwards, I basically take it down and I put it into my Practice Mastery Academy type of thing. And then also, the last thing was kind of an interesting thing. I feel like when things are a little bit slow, I kind of think entrepreneurial more so. And I think the main one is like I always think of, there's this question like, what's the one thing that you could do that would make everything else basically irrelevant? And so I think for us is if I had a unlimited amount of patience, like everything else would kind of be irrelevant. It would work in spite of me, I guess. And so having that infinite amount of patience, like one of our practices is fine. Yeah, but the new doctor, he needs an infinite amount of patience. So I think it's the key is like always be marketing. And so I was talking to this gentleman. His patient, his wife's a patient. He actually cleans and works on our autoclave. And I'm like, hey, do you like work with a lot of nail salons because they need autoclaves? And said, yeah. I said, well, can you give me your list of salons and introduce me to them and things like that? Because they might need someone to take care of their ingrown toenails and stuff like that. So that's something I hopefully there's going to be like a joint venture with this guy doing that. And then the last thing of the day before I go into the day here is I had a coaching call. I think I told you I was going to do a coaching call with a sales coach. I found the sales coach on Fiverr. And my focus is I want to get better at orthotics. And I thought, it was funny, I thought he was like going to teach me all these closing techniques and be all kind of sketchy and stuff, and actually not. What he did is we were on Zoom and he said, Don, explain to me, one of the conditions. So I explained plantar fasciitis to him, and I did my patient presentation and I showed my treatment sheet. And then he gave me feedback. And so, as I mentioned, if you guys want to get this feedback, I'll publish it. It's kind of how do you say it? It's uncomfortable. You can see the feedback from this guy and how inept I felt with this. But if you want to send me an email and I will publish it on my podcast. But I want to know people actually want to listen to it. And he gives me feedback. So I do my presentation, and then afterwards he says, Don, I like your idea of the first visit. You're kind of offering low ticket things, but he said the second visit, you're like scaring everyone because you go from like, okay, this is free, foam roller, night splint, all that stuff, and then next time, okay, it's like 3 sessions of Shockwave or 6 sessions now, so $1,500 plus a $600 orthotic and maybe amnio, and he's like, whoa, like I'm super scared here. And the presentation was fine, but he said also, it's like I'm less empathetic. And I feel like I'm pretty empathetic, but I think he's right, because when I do my presentation, and I'm paying this guy, so I might as well, take what he says until I find someone else that has better words for me. I find we're always like rushed. And that's what I feel. And, I'm going in there, I got 20 minutes. I know the problem. I know how to treat it. I know how to get him better, but that doesn't matter, he said. He said, Don, it doesn't matter if you know what the problem is, how to get them better. You have to be empathetic. And I know there are certain docs that are more empathetic than others, but he said possibly the reason you're not getting as much acceptance is because you're not kind of being empathetic enough and listening to them and going through the options and less saying like, okay, you're going to do this, and this. Because usually what I do is I say, okay, you're going to take meloxicam, you're going to do your night splint, your foam rolling. I'm going to see you back in 3 weeks. We're going to do an ultrasound. Like I say, like what we're going to do versus like getting them on board. And I know there's different preferences and recommendations. Some people say you have to be the doctor and tell them what to do, but this is more an empathetic way of doing it in what he feels, and this kind of makes sense, how I position myself in terms of empathy and getting them on my side. The first visit is going to dramatically increase the acceptance of things on the second visit. So I would like your feedback on this. So email me, don@podiatrypracticemastery.com. Like, let me know. Has anyone else struggled with this? Have you, watching yourself present, the things to the patients are it's super uncomfortable. But I'm going to keep going through this because I think it's going to really help me. And these are blind spots. I didn't even know that existed. I just do my presentation. I've done it hundreds of times, and this is kind of how I do it. And it makes me think maybe why, my colleague who spends a lot more time, does a lot more orthotics, but he may be a lot more empathetic than I am. And so it's kind of uncomfortable conversation. Okay, that's the rant for the day. Let's go in here for the day. First patient was a woman, 80-year-old female. She had flexible hammer toes, 2 on one foot, 1 on the other foot, causing painful callus. So I did in-office flexor tenotomies. So I did 3 of those, so 2 on one foot, 1 on the other. I got x-rays prior, and on 3 weeks when I see her back, I'm going to get x-rays again. And so she also picked up orthotics this day because she was a previous patient, and she picked up orthotics, and so we'll do a 2-week follow-up for the flexors and a 6-week for the orthotics. Next patient was a patient that came in. She had kind of a cavus foot type. She had a rash on the lateral right foot. I was treated in the past with I think a ketoconazole or something like that, and I did a biopsy last time. It did show tinea pedis. She did have some nail fungus. I took a nail sample. I'm going to see her back in 3 weeks. It could be fungus again, or it could be superimposed like a dermatitis. I don't give this that often, but I haven't done it all this year, but I gave her a combination. I gave her a lotrazone, so a combination steroid with antifungal. Next patient was a patient of mine with plantar fasciitis. I got an ultrasound. I showed her a bursa that she had at the bottom of the foot, and I did a cortisone. She's kind of a high maintenance. She's like, did my portal message, like, I don't know, probably 20, maybe not 20, maybe 10. But she was kind of an intense one. Another patient was a patient, this is a patient that, it's kind of one of these struggling ones. He did terbinafine, then he did diflucan for 6 months, and he still has kind of like that distal kind of lifting on the big toenails. The pictures look very similar, so I'm going to go to do itraconazole or Sporanox. I don't know if you guys have anything else. And the other thing I said, I could just pull off the toenail. But so I usually start with terbinafine, then I switch to diflucan, and then I go to itraconazole. Anything else that you guys have, let me know. I'd love to improve here. Another patient came in. This was a patient that came in, 58-year-old female. She has a pain on the second med head, and what I noticed, she had a little ossicle and didn't have it on the other side. And this little ossicle is causing her pain underneath there. It's a prominence, and so like I said, you can live with it. You can do an orthotic, or you can remove it. And she opted to remove it. I don't feel comfortable removing this in the office. Probably pretty easy, but sometimes they're hard to find. So I'm going to do it, and we're going to schedule that. And I told her I'm scheduling 6 months out, and she is perfectly fine with that. Another patient came in. This was a 78-year-old gentleman. He had plantar fascial pain. He had a lot of things going on. So on the left foot, he had an ingrown toenail. So I did a IND. On the right side, he had plantar fasciitis and equinus. So we did plantar fascia number 1 along with a cortisone injection. I think the reason I did the cortisone on this gentleman is just I don't know how good he's going to be at all the other stuff. And I just kind of I was in a rush. I just kind of wanted to get in and out with this guy. I don't do a lot of cortisone, but in his case I did. Another patient, this was a big win for me. This was a patient, a 15-year-old that came in for Swift as a second opinion from another doctor, and they had found my Swift book online. So they found the Swift book, they sent a message, I messaged them back, we fit them right in, and they were appreciative, they felt informed, and so this was a way that the Swift marketing worked. So if you want to see my Swift marketing, you can go to fixmywart.com just to kind of see how I do it. Put your email in there, you kind of get my email sequence, and this is what they did, and they're very pleased. She was actually a nurse practitioner. It was her daughter that she brought in. So I was pleased with that. Another patient came in. This was my EPAT. This is EPAT number 2. He was this gentleman that had a Haglund's repair by an ortho. There wasn't much of a bump there, but the reattachment really hurt now, the insertional Achilles tendonitis, so did Shockwave. That was the morning. Afternoon was a patient. He had on the medial 5th digit, he had an exostosis between the toes. We shaved it down with an exostectomy right in the office. Next patient was a 72-year-old man. We got an x-ray, and he came in for a second opinion. He had arthroplasties 2, 3, 4 on the right side. Second opinion, it's been a year, he's really swollen, and I'm like, that happens. Maybe hindsight would have been to do an arthrodesis versus an arthroplasty, but there was nothing wrong. He just wanted to know how we could accommodate his pain. And I said possibly doing like a crest pad. No one tried the crest pad, and I recommended some more anatomic shoes with stretch. So avoiding kind of a heeled shoe and trying more of a zero-drop shoe. We'll see how that works for this gentleman. Another patient, this was one that kind of scared me. This was a 12-year-old kid, and I did a wart removal, and I went past the base membrane, I want to tell you. So, I was down to fat, and this thing bled. And the problem was it was like a perfect storm. I think I talked about this before, but so he did it on a Friday. I said, yeah, you can, call us if there's a problem, or you can text a picture. The problem was, and this is something I fixed, he texted a picture Friday night, but no one checks the pictures till Monday. And so it said, we'll get back to you on Monday. He didn't know what to do. This guy went to the ED. And so everything looked fine. It was just bleeding a lot because these things bleed a ton. And another problem I made is I'm like, yeah, leave the bandage on a couple of days. And the bandage was just soaked, so he's walking around with a soaked sponge and getting blood all over the place. And his dad was carrying him around, and it was just stressful. So, hindsight, changed the dressing the next day. Another hindsight, I changed my texting. So when patients send a picture or text when we're not available, it says, okay, we're going to get back to you during the week, but if you have a urgent issue, call the office and you can talk to a doctor on call. So this one, but it looked fine. Like he's a 12-year-old kid. Like this ulcer's like pristine. Next patient came in. He's a follow-up. I'd seen him in the past years ago. He's 23 now. He had a chronic ingrown toenail. Did a matrixectomy on him with no follow-up. Once again, I'm trying to do these no follow-up things to avoid the low-level visits. And then this was a patient. He had Lamisil number 2 visit, so he got the terbinafine, all the other kit, and all the other stuff. And this was the guy that works on our autoclave, and hopefully he's going to give me his list of stuff. And then of nail salons, and I'll reach out to them. If any of you guys have any great ideas of how to reach out to nail salons, if anything's worked for you, let me know. But these are things I'm trying. And last patient was this EPAT. She's here for EPAT number 3 for Achilles insertional. I tend to find that these need 6, so I had her schedule another 3, and then we'll do a 2-month follow-up with her. So that was the day. Hope you guys found this beneficial. If it is, please share it with your friends, other doctors. Also, like it wherever you're at. And certainly, if you have other topics or ideas, or you think I'm off base, or you think you agree, like send me something, because it's a lonely world for all of us working, and this is kind of brings a little bit of community. Okay, thanks. Bye bye.